I think everybody's in the same boat, and I think that historically, though, cardiology has stood out because it's relatively easier to measure the services that we provide. We have specific transactions with patients, such as performance of percutaneous coronary intervention, PCI, for either an acute coronary syndrome or in the chronic stable phase of disease. We have interventions for atrial fibrillation, a catheter ablation procedure. We have interventions for pacing. We have interventions for defibrillators. Our surgical brethren have interventions around bypass surgery, valvular implantation, whether it's transcatheter or surgical, for example. And these are easily measurable across populations. Outcomes are more easily tracked, and as a result of which, cardiology and cardiac surgery have always kind of stood out with respect to the quantitative analysis that can be brought to bear on what is our value proposition. I think that the value-based proposition affects me at a place like the Brigham and Women's Hospital in ways that may be somewhat different from a community-based practice, and that derives in part from the fact that an academic medical center is usually a quaternary center to which patients typically at high risk and high cost are referred for care of complicated problems with numerous comorbidities and high stakes. And the delivery of value-based care under circumstances in which patients may be outliers with respect to their risk profiles is challenging. And, but it obviously is something that can be tracked over time. Academic medical centers still continue to provide a lot of secondary care and tertiary care. But in cardiac surgical programs and cardiovascular medicine programs in academic medical centers, we tend to see more of the pyramid than the base with respect to the complexity of disease. So the value proposition needs to be ratcheted up on the basis of the aggregate risk of the population that you serve. I think that it's been several years now over which physicians have aggregated together in order to maintain their clinical profiles. I think that the days of the solo practitioner are over and have been over for a period of time. The days of the large private groups that are not affiliated with an academic medical center or a large health system are also challenged, but depending on the size and the characteristics of the group, they have proven themselves successful in multiple locations across the United States. I think the bottom line is that size matters, and the larger the size, the easier it is, I think, to begin to balance this equation about volume and value and the reimbursement stream that accrues from that. I think to do so in a solo practice, the overhead is just simply too high to maintain a viable long-term existence under current circumstances. The cost of health IT is just one example of the expenses incurred by a practice in order to deliver according to the current specifications. It's not trivial. Well, I'd like to think of them not so much as small-town doctors, but as caring individuals who have nurtured a practice of cardiology and medicine over several years, who have become trusted sources for their patients and families. I think we are all challenged, whether we are in an academic medical center, at the VA hospital, in a community-based practice or a small practice. We are all challenged given the number of things that we need to accomplish over the course of any one day. We are really challenged to provide that personal touch that's really necessary to help patients through difficult times or to help them understand the long-term implications of their disease state. And I think it's something that the practicing community very much continues to treasure, wants very much to protect, and is struggling with how to find the appropriate time in which to do that against all of the demands that have been placed on us of a clerical and administrative nature. Well, I think that each of us has a different, has his or her own practice style, and to a large extent, I think that people try to do the very best they can to provide that. And we recognize that we spend increasing hours per week in doing things that do not necessarily add to the patient experience. And that means that we have to be better at those elements that we can control with respect to what the patients take away from their interaction with us. And I think that this is something for the House of Medicine to to try to come to grips with, so that we don't lose the specialness of the patient-physician interaction in the process of trying to be efficient.